This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to another episode of It's Not In Your Head with Justine Feidelson and Dr. Dan Bates. Hey, Dan.
Hey, Juz. How are you?
I'm well, thanks. We are looking forward today to going over a couple different ways to think about pain and express pain, because whether you're a patient or a physician, it is difficult to put into terms that I think everybody relates to and also experiences. And unfortunately, oftentimes it comes across, especially the way that pain science interprets and communicates it, as if it's in your head as a patient. And the entire purpose of this whole podcast is basically to explain and walk through and teach you guys why pain, especially when it's highly amplified, is not in your head. But in order to explain that, we need better ways to think through and go through that process, which Dan has tried for years to do better with his patients and has actually put together a couple different analogies to think about pain so that it makes more sense to you as the patient.
Yeah. So like over the years, just like everybody else, I got it wrong. And as I was trying to explain pain to somebody, I would give them the sense that it was all taking place in the head. And you know, as soon as you make someone feel that they are imagining their pain, that's it. That's the end of the therapeutic relationship. And I can't do my job because I can't actually get somebody better. So I, over a long period of time, worked out how to use the right words. Sometimes I probably still get them wrong, but at the end of the day, that fundamental understanding that you're not imagining your pain. And the way it's explained at the moment generally is that you have either no pain signal going to the brain, and so it's being generated at the level of the brain, or you have misinterpretation of a signal that is then being perceived as pain. Now, in some ways that is possible, but I think that in most cases that's not what's actually taking place. And there's other ways to think about it that allow you to think more broadly about how you're going to approach a patient and gives you more therapeutic options. So for this episode, we're going to go through pain as a sound system. I explain pain as a sound system. We'll go through it. It's a little bit of a talky type presentation. I'll show you the presentation and you sort of get a bit of an idea of how it all fits together. What we'll do in the next episode is we'll go through the pain pie. So the pain pie is slightly different, but once again, it's just that idea that you have a set of things that you can work through. And just like any pie, a pie is not made up of one thing that makes a really crappy pie. It's made up of lots of different things, and you got to break it down into what it's made up into. So let's kick off. I'll get going with explaining pain as a sound system. So excuse me while I disappear into the background. So when I think about pain, there's multiple components to it. So the first two components are that you have a singer and you have a set of microphones and some leads. You then have an amplifier and speakers. You have the band, and then you have the audience. So within this system, the singer are body parts. The microphones and leads are nerves. The amplifier is the spinal cord and the brainstem and the brain. The band is context. The audience is the patient. So when we're thinking about context, what we're talking about in that setting is we're talking about how the patient has experienced pain, what they've been told by other doctors, what they've seen on images. So, we see so many times, like I'll have someone come in and say, oh, my pain is coming from my 4-5 disc. And on their MRI, it'll say, oh, they've got mild, 4-5 disc degeneration with a disc bulge. You know what? That is so common. And when you look at the science behind it, there is no link between that imaging finding and pain. But it might be the only thing that is there. And so it becomes the patient's belief that that's what's causing it. Similarly, like clinicians, where people are wanting to validate the pains being experienced by the patient, they might say things like, that is the worst I've ever seen. And so, people then come and talk to me and go, oh, the surgeon said it was the worst one he's ever seen. I'm like, well, yeah, but that doesn't mean we can't like get on top of it and we can't fix it. And then, people have got their own thoughts and their beliefs and their understanding, their own experience of pain, or pain experienced by their family or their friends. And that also influences the context of how they experience their own pain. Within this, the patient here it's not one person. I haven't shown it here as well. The patient is like one person. No, the patient is multiple people, because pain doesn't just affect you. The pain affects the person suffering, but their family, their friends, like their work, society. I see pain as a social disease. And so one of the main reasons why I'm doing this is because if we can halve the pain of 1 million people, not only do we change those people's pain, those individuals' pains, but we change their family, we change their friends, we change society around them. And that's what I think we have to offer, and what I hope we can make larger changes with. So when you're looking at this at a whole system, what normally takes place is that if you think about when you roll your ankle, so you roll your ankle, you do damage to the ligaments on the outside, that gets picked up by the nerves, which transmits it to the spinal cord, and it comes out the speakers, and you get an ouch. And then the resultant thing is that you then start to protect yourself. So you get an increase in your heart rate, your blood pressure goes up, you become more alert because you're looking to now protect that ankle you've now hurt. You become more cautious as you're more protective. You start to limp. Once again, you're protecting that injured area. And soon after that, you actually have a decrease in your mood. Most people then start to go into a healing phase, and basically you get a drop in your mood and things start to calm down and you start to move into this healing process. Now, what happens with chronic pain is that there doesn't end up being one nerve. There becomes hundreds of nerve endings. And that then starts to involve multiple nerves that then are feeding into the spinal cord. And your amplifier gets turned up from 2 up to 10, or 2 up to 8, or whatever. It's now gets turned up. And then when you hit the speakers are now also turned up. And so they're now going from something reasonable at 2 to now they're going up to 10. And so your ouch becomes an ah, and as it starts to amplify everything else, right, the increased heart rate and blood pressure and fear becomes anxiety. Your cautiousness becomes fear. The limp becomes deconditioning, and the decreased mood becomes depression. And all they are just amplifications of a normal pain process. And then what goes on once you've moved into this more prolonged period of pain is you get loss. And that's actually what everybody comes to see me for. Most people don't actually come to see us for it hurts. I will guarantee most people do not care if something hurts. What they care about is what they've lost. They've lost their ability to do the things they want to do. They've lost their role in the family. They've lost their role at work and their position, and they lose their sense of self. And that's what pain takes away. And pain, fundamentally, it's a thief. It takes away the things you love. And so, that is what we've got to do. What we've got to do is we've got to move people from having pain, stealing what they love, and taking back what's theirs.
Yep, agree.
You can then start to break it down into each different component. So pain that comes from body parts, the technical term we use for it is nociceptive pain. Unfortunately, it's a stupid word, and it's hard to think about. But anyway, nociceptive pain is pain that's generated from body parts. So that includes pain that comes from backs, and also pain that comes from your internal organs or your viscera. When I'm seeing somebody, what I ask them to do first, we get them to draw their pain. We will take you through this stuff in later episodes about how you start to break your pain down into individual components. But when I ask someone to draw their pain, if it is nociceptive, what you'll find, it tends to be quite focal. And you can see here, this is an example of somebody that will draw focal pain. And if they're drawing that below their belt line, that's golf ball to tennis ball in size, it's most likely a sacroiliac joint, but that's an aside. What it actually feels like, it's an ache, it's sharp, it's dull, it's pressure, it's throbbing, or people just can't actually define it. They just go, oh, damn, it's just sore. It follows a specific pattern. So it tends to be focal. It tends to be intermittent. So it comes and goes. It tends to be proportional. So it's little injury, little pain, big injury, big pain. And it'll have specific things that make it better and specific things that make it worse, that makes it worse. The next thing that takes place is it has a set of features. So if there's inflammation involved, it's worse in the morning, improves your warm up, worse your cool down, associated with stiffness, goes away a little bit with anti-inflammatories. If there's muscle involved, you get muscle tightness and trigger points. If you've got bone involved, it wakes you in the middle of the night and gives you pain on impact. So if you sit down, the pain goes away, you stand up, it gives you pain. You see most commonly in things like stress fractures and a range of different things like that. If you've got something that's broken, okay, or busted, you get painful clicking, clunking, instability. In this term, I refer to this as mechanical pain. Mechanical pain is traditionally referred to, you sit down and your pain goes away and you load it and you get pain. I think slightly different about it. And then you can get pain that comes from blood vessels. So pain that comes from blood vessels gives you pain on exercise and it goes away quickly at rest. The next type of thing that we can look at is pain that arises from nerves. So pain that arises from nerves is neuropathic pain. And so when you draw it, it tends to follow a certain pattern and it'll be in the distribution of the nerves. So neuropathic pain, when you ask what it feels like, it's burning, pins and needles, numbness, itching, crawling, painful cold, painful squeezing, and electric shocks. If you examine somebody that's got a large amount of neuropathic pain, they get this thing called allodynia. So you just run your finger gently over their skin and it causes pain. They can get hyperesthesia, which is kind of like numbness effectively. So they just don't feel things very well. And they get this other thing called summation, which is kind of interesting, is that it's like if you're petting something, like you pet it, but each time you pet it, the pain gets more and more and more and more. Yeah, it's an accrual of pain. From a pattern perspective, what it does, the neuropathic pain will wax and wane. It's generally there most of the time, but sometimes it's better, sometimes it's worse. But what it does a lot of the time, it gives you these intermittent spikes, and commonly those intermittent spikes come out of nowhere and they're just random. And so you can just be doing nothing, sitting on the couch watching the telly, and boom, all of a sudden that ankle fires off, and you're like, where did that come from? And that's very typical of neuropathic pain. Its distribution will be in the distribution of what nerve is involved. So neuropathic pain, which I didn't say to start with, is either an injury or dysfunction of the nerves themselves. If the nerve is a peripheral nerve, then you'll get pain in the distribution of the peripheral nerve. If it's in a nerve root, it'll be in the nerve root. And the nerve root is the part of the body where all your peripheral nerves kind of come together, like a highway will be joining together smaller roads. And just before it enters into the spinal canal is the nerve root. And if you've got issues there, you get pain that's in that entire distribution of that nerve root. You can also get pain that arises from a plexus. So that's where you get all this crossing over of nerves. And once again, it's a very broad pain. And if you've got pain that's, that arises post-stroke or is affecting the spinal cord or is higher, it will then lay out in a broader area. And you may get like an entire half a body that will be involved in your pain. The next part of pain is called nociplastic pain. So nociplastic pain, once again, difficult word, suboptimal. It's driven by a process called central sensitization. And so when people draw it, what they will draw is something like this. They will come in and they'll scribble over everything. And so, what it feels like, it's an amplification of pain. And this is where the nerve roots, the spinal cord, and then the upper components of the brain start amplifying the pain. And that amplification process is called central sensitization. And so what it can feel like, it either feels like body part pain or it feels like nerve pain. So it can be ache, sharp, dull, pressure, or sore. It can be burning, pins and needles, numbness, itching, crawling, painful cold, painful squeezing. But the important part about it is its pattern. So it goes from being focal to it spreads. It becomes non-anatomical. So it goes from being intermittent to being constant, or it goes from being intermittent to being prolonged. And so you push on somebody and the pain lasts for, 2 to 3 minutes after the stimulus has gone away. Most importantly, it becomes disproportionate. So instead of having little injury, little pain, you get little injury, big pain. It also becomes unpredictable and multiple things trigger it off. And instead of specific things make it better and worse, everything just makes it worse. Now, specifically, how it's defined is it's defined as disproportionate prolonged pain on palpation, so touch with 4 kilograms of weight, which interestingly is a fair bit. Like
Yeah,
to
that's not
get an
light.
idea about how much 4 kilograms of weight is, the easiest way to do it is if you're sitting somewhere at the moment, you can reach out in front of your desk, push down onto your thumb until, like, use your thumb until your thumbnail blanches. So like you push all the blood out of your thumbnail. That's about 4 kilograms, which is actually a fair amount of weight. Anyway, I've got lots of people that require far less than 4 kilograms of weight to make it hurt disproportionately.
To evoke a response, for sure.
Using heat, so heat at 40 degrees or 104 degrees Fahrenheit, like please move into the 21st century, or 20 degrees of cold, which is essentially room temperature, or 68 degrees Fahrenheit. So you can basically place, I use a lot of the time a tendon hammer, which part of my tendon hammer is metal, and it's at room temperature, and you just place it against the patient's skin. And if that actually generates pain, well, that's a good indication that they have nociplastic pain. Now, to have nociplastic pain, there's a number of other components to it. And so they are what we recognize as features of pain. And so technically, when you look at nociplastic pain, it is disproportionate pain in response to touch, heat, and cold associated with sensory hypersensitivity, sleep disturbance, fatigue, and cognitive dysfunction. So that's brain fog in non-doctor speech. If you look at central sensitization a little bit more broadly, what that includes is mood disturbance on top of those and dysautonomia. And we're going to run through each one of those components now. Sensory hypersensitivity is basically where all your senses are amplified. So easy to pick the first one. So we're talking about pain in this setting, or more the point, more correctly, it should be nociception is amplified.
Right.
So if it's widespread, we label that generally as fibromyalgia. If it's in a focal regional area, we label it as different regional pain disorders. So temporal mandibular joint pain, probably IBS, so irritable bowel syndrome, probably bladder pain syndrome. And there's a range of other pain syndromes that are quite focal that fit into this sensory hypersensitivity piece. The other thing to have nociplastic pain is you need to have sensitivity to light, which is called photophobia, sensitivity to sound. Now, sensitivity to sound is an intolerance of sound. So that's phonophobia. And when it gets worse, we then label it as hyperacusis. Sensitivity to smell. So I think a lot of the times we label the condition multiple chemical sensitivities as that's actually sensitivity to smell. So people get sensitive to perfumes. They walk down the detergent aisle at the supermarket, and then all of a sudden what we see is that they're feeling nauseous. And like smell, when it's super sensitive, makes everyone feel crook, can make you feel light in the head. And as a disease process, in part, we label that as multiple chemical sensitivities. Although, MCS is obviously more than that. People get sensitive to touch, and not in the setting of touching other things, but being touched. They just don't like being touched. They get heat intolerance, I think, so they become sensitive to heat, sensitive to cold. And I believe that in this setting, Raynaud's disease, for those people that do know what it is, you've probably got it. For everybody else who doesn't know what it is, you probably don't have it, but it's basically what happens is that when you're in a cold environment, your fingers, most commonly fingers or toes, will go white. And because you get constriction of blood vessels because it's your body's essentially looking to try and conserve heat. But what you've got a disproportionate response that's prolonged in response to the cold. So similarly, it fits into that, sensory hypersensitivity piece. Food intolerances probably fit into this to a certain extent, although food intolerances have a couple of different mechanisms. And I also wonder whether what we see in a number of patients is alteration in their balance. So their vestibular system comes off, and how we see that present is an increasing number of falls. And all those sort of things start to tie together. Interestingly, when I start talking to patients about this, that's when they start going, oh, actually, yeah, I've got that. Yeah, is that what that is? Oh, yeah, I've got that. So basically, the pain is being amplified, but so is every other sense. Sleep disturbance comes on next. And so sleep disturbance can be, a number of different things. So insomnia is difficulty with getting to sleep, difficulty with staying asleep, and waking early. So you wake early before you plan to wake, and you have trouble getting back to sleep. Other people have unrestful sleep. So they wake up and they just don't feel like they've had any sleep at all. And then you can get hypersomnia, which is like when you sleep tons in response to having crappy sleep at any rate. The next thing that people get is fatigue. So fatigue is they get a lack of energy, they get physical fatigue, they get cognitive fatigue. This very much ties into leading into chronic fatigue syndrome, but chronic fatigue syndrome, although it has all these components to it, has a very specific diagnostic criteria, which is you need to have post-exertional malaise. And so post-exertional malaise is where you exert yourself and then you have significant worsening of your hypersensitivity, sleep disturbance, mood disturbance, fatigue, and dysautonomia following that exertion that will last for a prolonged period of time. So it's a disproportionate, prolonged response to exertion. To a stimulus. Cognitive dysfunction, so brain fog. So this is one of the main things that you see particularly with nociplastic pain, so this amplified hypersensitivity to pain, and people get difficulty with thinking, with concentrating, and with memory. And most of the time, let's be honest, it comes with memory first and concentration second, and thinking a little bit further down the track. Mood disturbance. So mood disturbance is, not surprisingly, if you've got lots of pain, people get irritable. Catastrophizing probably comes into this, and this is sort of interesting in itself, in that if you describe your pain in catastrophic terms. So this is the worst thing ever. I have patients who will say, I feel like I'm being hit by a sledgehammer. I'm like, okay, I have no doubt your pain hurts a lot, but being hit by a sledgehammer means you're laying on the ground, not getting up. So where their pain is really, really bad, the description of it is disproportional. And interestingly, catastrophizing results in a decrease in what's called descending inhibition. So descending inhibition is how your body controls a lot of your pain. So your brain sends signals down your spinal cord and it helps turn off pain quite globally. When people catastrophize, it's been shown that descending inhibition decreases, and so it worsens their pain. So one of the things we can do is you can retrain and start changing your language and changing your thoughts around that, and it can actually help decrease your pain.
Which relates to that context piece of the amplifiers, right? The person's belief, their attitude towards how you're starting to feel about your pain dramatically impacts its effect on you.
Yeah. Perfect. And then, of course, mood disturbance then steps into anxiety. We all have a degree of anxiousness. As soon as your anxiousness or worry becomes, once again, disproportional, or it starts to impact on life negatively, we then label it with anxiety. And then similarly with depression, everyone gets sad, but once it becomes prolonged, disproportional, it negatively impacts on life, it's then a condition. The final piece is dysautonomia, and this is probably the most interesting and complicated piece, because what it does is it is a ton of weird symptoms that are hard to explain. So the autonomic nervous system, automatic. So if you think about what gets managed automatically, the things that get managed automatically, our organs, so our heart, our lungs, our kidneys, liver, gastrointestinal tract, your body just manages that. Now, when the regulation of those becomes dysfunctional, we then refer to it as dysautonomia. And so you get a number of different symptoms. So the first type of symptom you get is, or not the first, but one of the types of symptoms you get is orthostatic intolerance. So what does that mean? That means that when you stand up for a prolonged period, you get lightheaded, you get dizzy, you get palpitations, and you get nausea, and you feel pretty terrible about it. Now, a lot of the time, people then get the label of POTS. Now,
Yeah.
POTS is positional orthostatic tachycardic syndrome. Okay, so the piece there, so what does that mean? It means when you stand up, your heart races. Now, interestingly, more wiggles and big stretching going on. I feel like doing some big stretches.
Well, the funny thing is when one is talking themselves, that in itself is a distraction. But when you're passively listening for an extended period, you cannot help but feel it more.
Do I need to take that as like a hurry up, Dan? Sort of.
No. This is the presentation part. No. Keep it going.
All right. So with POTS, the diagnostic criteria for POTS is that your heart rate goes up 30 beats per minute after standing up for 3 to 10 minutes, but you have no change in blood pressure. And so what we see with a lot of patients is that their blood pressure actually goes down and they get a corresponding increase in their heart rate. So that's actually normal. That's a normal tachycardia in response to a decrease in blood pressure, but you still have the symptoms of orthostatic intolerance and you still feel crappy. It just doesn't match the diagnosis of POTS. But interestingly though, the treatment ends up being pretty much the same, but it's not the same diagnosis nonetheless. You also get gastrointestinal symptoms, so abdominal symptoms. So people get abdominal pain, bloating, nausea, diarrhea, constipation, and that gets labeled as irritable bowel syndrome. If you've got bladder problems, you get bladder frequency, you get bladder urgency, you get this sense of incomplete emptying. That ends up being, when it's associated with pain as well, labeled as bladder pain syndrome or interstitial cystitis. One of the other things that I think is probably a little bit more common and people don't talk about it much is abnormal sweating. So that's called hyperhidrosis. And abnormal sweating is a increased sympathetic outflow. So part of your autonomic nervous system, it gets split into two main components. Well, three actually, technically. So the first component is your sympathetic nervous system. And if you're thinking about what does that do, that makes your heart go faster.
Fight or flight.
Yeah. So your parasympathetic nervous system slows your heart rate down. And then the third part of your autonomic nervous system is the gastrointestinal nervous system. And so that runs of its own thing. Interestingly, there is, as I remember, there's actually more nerves in your gastrointestinal system than there is in your brain. So there's tons of nerves around that. So it's called the enteric nervous system. The last piece, at least in this little piece of the talk on dysautonomia, is you can get blurry vision. And so the reason why you get blurry vision is that your sympathetic nervous system dilates your pupils, your parasympathetic nervous system constricts them. When you get dysfunction of those components of the autonomic system, you get wiggy control of your eyesight and you then get blurry vision. So a lot of the strange symptoms patients get are about dysautonomia. And so when people have got high levels of disproportionate pain, they start getting other symptoms. And that is the entire central nervous system starting to become dysfunctional.
Involved. Yeah. And I wonder if the sweating one in particularly is more common. I see it very often in the CRPS population because there's such a sympathetic drive to those symptoms. So then when you do develop the dysautonomia component, it's one of the more common ones, I would say, instead of a lesser common one. But that's why all of these I start to see in these complex, long-term, unaddressed chronic conditions where you start to accumulate all of these different amplifiers and systems that start to get affected and involved.
I don't know whether it's just CRPS. I have only really been asking about sweating recently as I start to, as I'm learning. And like one of the reasons why we're doing this, we're trying to work it out. And that, the whole sweating thing, I'm going to go with nearly everyone says they have abnormal sweating when they're centrally sensitized. I don't know. I will get back to you about that answer in a couple of weeks when
Or
I
we're on that spectrum.
continue to ask everybody. All right. This is an influence. So if you're not watching this, you're listening to it, what it says on the screen is
That's the takeaway.
if you're confused, they are sensitized. And so when I've been teaching this over a number of years, you need a trigger to see the sensitization. So what happens a lot of the times, the patient will come in to see me, and I'm thinking about this in the context of a clinician. But even if you're thinking about this in the context of yourself, so a patient will come and see me and they'll give me a history. Now, when somebody has nociplastic pain and they have central sensitization, what's going on for them? Okay, so number one, they have sensory hypersensitivity. So they're sitting there and the light in my room is hurting their eyes and everything around them feels a bit too loud. Okay, they are sitting there having had sleep disturbance. So they haven't slept for months. They're completely fatigued. They've got brain fog. So they can't think very well. They can't concentrate very well. And when I'm asking them questions about how things like have been taking place, they can't remember very well. Not only that, they're anxious and they're depressed. And they're probably sitting there, if they've got dysautonomia, they're kind of sitting there feeling like they need to go and take a pee. And so as a result, like when patients are like really sensory sensitized, they're terrible historians. And as a result, like the story becomes really confusing and it becomes really frustrating. And so I would find that I would be getting frustrated because I did not understand what the hell was going on. And when I realized, hang on, I'm frustrated. I don't know what's going on. The patient's sensitized. Woohoo! It needs that piece in the story. Like a lot of the times that you have to recognize it as a clinician. This doesn't make sense.
Boom.
The patient's sensitized. Go looking for the sensitization. And now,
And this
as
is
we
also
work through this,
yeah, right. Whereas clinicians, then we need better tools and assessments to pull this out of patients because it is very difficult for a patient to spit this out at you. Yeah.
Yes. And we'll go into this more detail in the next how many episodes we do of this podcast. But that's it. The key is then recognize the patient is confused and then teasing out what are the components of their sensitization. And we're going to do a podcast probably 3 or 4 down the road from this one that will tease sensitization apart into lots of little pieces. So the next part that comes into it is then you've got to look at, when you're thinking about pain as a sound system, well, how can you treat people? And what have we got? Like, we've got interventions and surgery. So interventions and surgery, what they do is they are essentially addressing things at a body part level or at a nerve level. Medications are generally working on the nervous system, and they'll be or on the peripheral nervous system and down regulating both peripheral sensitization and central sensitization. You've got exercise that will also act at a central level. You've got psych and an education that works up on the speakers. And then you got diet that probably works on everything.
Yeah, I mean, you can see a lot of these are global interventions, right,
Yeah.
rather than system specific.
Yeah. So when you get to the end of this, that's pain as a sound system. And if you're looking at this on the video, you can obviously see how the picture lays out. The important thing is, yes, pain is perceived in your brain, sure, but
Like everything.
it is driven and amplified by multiple things. And not only can you change the way you think about your pain? Sure, change the way you think about your pain. It'll help decrease your pain. Great. But you can go and you can look at what body parts are involved, what nerves are involved, what amplification is taking place at the spinal cord.
Right.
What's the context of this? How can we change the context of your pain? It's all those things that can then alter not
Your
just
output, right.
not just thinking about it, and it's not just in your head.
And you can see how with all the different pieces of pain, then you can start to look at what interventions address the different pieces of that person's puzzle, so to speak. And Dan's metaphor of pain as a sound system is such a good way of seeing, like you said, all the different pieces that contribute to pain and how, whether it's from an input or an output perspective, it's rarely, if ever, one thing. And the structural component of pain That has to be clearly identified, diagnosed. The other components of pain around it have to be identified. The amplifiers have to be identified. And that's really hard if central sensitization itself, which is very common in most progressed chronic complex pain presentations, is not picked up or not treated. And so looking at pain as a sound system allows you to see all the different players kind of like on a team, and start to look at then every piece that you can impact as a patient versus what pieces can the physician impact with their tools and their disposal. So the pain as a sound system analogy and metaphor that we've kind of fine-tuned and tweaked and added those elements of sensitization to is what then brings us to our overarching metaphor of pain as a puzzle, right? And working through and figuring out your puzzle pieces. And that's what we're going to work through in a number of subsequent episodes now, other than pain is a puzzle itself, each individual piece around nociceptive, neuropathic, right? Sensitization, et cetera, so that you can start to tease out and understand, oh my God, this is a big piece of my pain, or, oh man, I haven't even thought about how much that would be adding to my output. So the level of output is a response to a myriad inputs over here on the left that we're responsible for some of it, and others we have to outsource because we can't mindset our way out of, screaming nerves. But you also can't just do an ablation and think that you're going to be fixed.
Yeah.
So thanks for going through that, Dan. That was really good.
No worries. All right. So what we'll do next is, if you're interested, you can have a look at the next episode. Next episode will be a bit shorter. We'll just go through pain as a pain pie. It's another way to think about it. Similar concepts, but if you've got different ways that you can think about pain, for some people, pain as a sound system works. For other people, it doesn't work, doesn't fit. So what we'll do is have a look at the next episode, have a look at pain as a pie, and we'll talk again then. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.